kind of centers around the big event, sure.
With 2 patients, whenever you
Yeah, and they're linked. Even after delivery, they're linked, right? Okay, which is very unique. What else?
More promoting wellness rather than responding to illness.
It's so different. This is a wellness-based specialty. This is not an illness-based specialty. And it's very difficult for students to sometimes flip that part of their brain. I've had students tell me before that OB clinical is quote unquote boring, which don't get me started on my opinion of that. But they're so used to taking care of people that are like needing help to the bathroom or needing, those kinds of things, and a lot of these patients don't need that. Okay, so we'll talk more about that in a minute. What else?
Is there vital signs?
What'd you say?
The vital signs are all really different than what we've done before.
Especially for which part of this specialty? The infants, right? Way different than adults, absolutely. What else?
There's sick, like, illnesses that you'll never deal with in any other situation.
Okay, sure. We deal with some different pathophysiologies that we don't usually encounter elsewhere, sure. What else?
Maybe like you're educating the patient.
Yes. First of all, I really get aggravated when nurses tell me they don't like teaching. Or if I try to recruit them to come teach here, they'll say, oh, I don't like teaching. And I'm like, how are you a nurse and you don't like teaching? That is like a huge role of all nurses, right? Should be. You're doing it right. But especially in this specialty, there's a lot of teaching. I like to tell people that in OB, we don't typically save lives as often with chest compressions and rescue breathing. We save lives with teaching. So it's not as immediate, but the impact can be just as great, if not greater. Okay, what else? Anything else you're expecting will be different or you've heard is very different in OB as compared to your other clinicals? There's one really obvious one that I don't think anybody's been brave enough to say yet. That is that's a big part of it. A lot, especially on labor and delivery, for sure. You're dealing with mainly female patients. I always tell people, as an OB nurse, most of the penises I dealt with fit in a diaper. That's about it. Okay. So how's that going to change our nursing care as compared to other liberals? What are we going to see a lot more of? A lot.
Pain?
Oh, sure. Yeah. Good one.
I mean, I don't want to be crass, but a lot more vaginas.
Yeah, a lot of vaginas. Uh-huh. What else? What goes with that? That feeds these guys. Lots of breasts, yeah. And to be blunt, everyone looks different. And I think that's something that it takes people who are used to working in this area a little while to get over, is the diversity of body parts. So we have to become comfortable that in this specialty, that is what we work with. I love to tell the story. First of all, you guys will never be paired with patients who have not okayed a student, okay? But I'd love to tell the story of a male student I had at, when I taught clinicals for Columbia College, okay? So if you're taking care of a couplet, you're taking care of the mom and her baby, right? And if her baby's breastfed, just like all of our patients, it's our job to make sure they eat, right? Okay. So I went into a room with him at Boone Hospital, and the mom needed help breastfeeding. And I said, are you okay if I help you with that? And she said, sure. So I barely bent over to start helping her, and I leaned back to grab the student to tell him to come around to their side, and he was gone. And it was very quick. Like, I still don't know how it disappeared so quickly. And so I thought, hold on just a second, and I went out in the hallway, and he was out there. And I said, Mike, what are you doing? So it was his fight or flight. A breast came out, he bolted out the door. Now, why do you think he did that? Because it was very quick. I don't even know that he thought about it. But why do you think he did that?
Or they want better privacy.
Yeah, I think he went into privacy, I'm a male, and just, I think he just, fight or flighted. But it was funny because it was so fast. And I said, come on, let's go. And we went back and he did fine. But we're going to be seeing a lot of those things that are typically covered by gowns, okay? So we do need to get more comfortable with that. And just ask if you have questions. Anything else you're expecting to be different with maternity nursing? You guys have come up with a lot of good ones thus far. Okay, how so?
Well, like whenever they're in the labor, whenever they're very vulnerable, and
Yes.
and everybody is always listening to this one, that's what I was sure.
Okay, super, very good. All right, great job, guys. Okay, so in this unit 1, these are going to be our focuses. Issues and trends in maternity nursing, cultural issues, complementary and alternative therapies, and then we have a few other ones like technology, teaching, professional behavior, and the healthcare system. Okay, before we really delve into topics, let's do some term reviews. Okay, so partum, typically it's like the Latin root word for giving birth, for being in labor. So antepartum patients are pregnant patients who are not in labor. Pregnant patients who are not in labor. All right, some hospitals actually have an antepartum unit. What are some reasons that somebody might be hospitalized as an antepartum patient? Preeclampsia, who said that? Okay.
Maybe they're in a car wreck.
Okay, maybe they had some sort of trauma or an accident of some kind and they're being monitored, sure.
I had a kidney infection, so I was.
Okay, sometimes it's truly a medical surgical thing, they just happen to be pregnant. And I don't know if you guys have noticed this, but most floors are totally uncomfortable with pregnant patients and do everything they can to put them in a wheelchair and run them to the OB floor. The ER is notorious for that. Yeah, so sometimes they're hospitalized for truly medical surgical things, they just happen to have a uterus that's got an inhabitant. Okay, what else might cause someone as an antepartum patient to be hospitalized?
Preterm labor.
Okay, preterm labor, sure.
Any issue with the fetus?
Okay, anything that they're monitoring for fetal condition, sure. Okay, so now we move on to intrapartum. Intra means within, right? So an intrapartum patient is in labor. These are laboring patients. And then, that you guys can figure out what postpartum means. That is after labor, after delivery. Okay, we're going to talk in a few minutes about a specific window of time, but the actual recovery from childbirth, the true postpartum window where they think it takes how long to heal is usually about 6 weeks. However, any complication or cause of death or depression or anything that can be related to the pregnancy, they consider it postpartum for that first year. So when they do maternal mortality statistics, for example, they look at that year afterwards. Okay, now we'll move on to babies. All right, this is important because sometimes students inadvertently use the wrong term. I don't think they mean to, but I want to make sure. So when we talk about a fetus, we're talking about a baby that is still inside of its mom, attached to the cord. Now later this semester, we'll talk more about when it's truly an embryo versus a fetus, etc. But that's not where we're at yet. So just anything that's still inside of a mom, attached to the cord, is a fetus. Okay, after we cut the cord and the baby's out, it's now a neonate or a newborn. Okay? So as soon as we cut it off of mom, we are no longer going to talk about fetal heart rates. We're going to talk about neonatal heart rates. Typically the definition of a neonate is the first 28 days of life. And then typically infant encompasses the first year of life. Okay, questions on that? Okay. So when you hear the term obstetrics or obstetrical nursing, what we're talking about is the branch of medicine that concerns the management of pregnancy, childbirth, and postpartum. Okay, notice the parentheses I have after postpartum. I don't really know how to say this word well. I think it sounds weird, but you'll see it in textbooks and you'll sometimes see it in providers' notes. The puerperium is that 6-week window after delivery. It's like a postpartum period of time. One place that you may see it is if a mom develops an infection and is rehospitalized after having a baby, they'll call it a puerperal infection. So it means postpartum infection. Okay, so this is why we often see women's health care providers called OBGYNs. Women getting care for non-pregnancy issues, that's the gynecology aspect. And some providers just do gynecology. They no longer do or never did obstetrics. But the obstetric component focuses on pregnancy, childbirth, and postpartum. Okay, and then under the umbrella of maternal child health nurses, there's many different roles and positions a nurse can seek. Probably the most obvious one is a staff nurse on labor delivery, postpartum, the newborn nursery, or many hospitals have inpatient lactation consultants. Some hospitals categorize the NICU and pediatrics under maternal child health. Others have it as two separate ones. Nurses can also work in a clinic, such as an OBGYN office, pediatrics office, or another subspecialty that's related. One thing that's a growing trend that's fantastic is lactation support after hospital discharge. So for example, several pediatricians' offices employ a lactation consultant, and several pharmacies do now, which is a really genius move in my opinion. Whaley's here in town has a lactation consultant. In Columbia, Kilgore's has had one for close to 20 years. So that's another role that someone who works in the maternal child specialty could see. I don't see this around here, but dear goodness, I wish we did this all over the nation. Postpartum home visits. Some hospital systems have that, and I think that would reduce a lot of the risks and deaths that we see in this country, is if we had better follow-up when people got home. So some places you have that, and that would be my agree with that one lottery. So make sure all moms that went home with babies had a postpartum follow-up visit, and possibly several. There's also wellness-based prevention programs. And then there's more genetics and infertility care, and as a subspecialty is growing astronomically. So that also falls under this umbrella. Okay, questions for Devon? Okay, these are the two that you won't have. Okay,
I'm sorry, I do have a question.
yes.
What's the difference between a midwife and a nurse midwife?
Oh, good question. There's two separate degrees. There's the professional midwife and the nurse midwife, so you'll see CNM and CPM. I don't personally know the difference, but I think it's kind of like how you can have an RN that has a BSN and you can have an RN that has an associate degree. So I'm sure there's just some differences in how the schooling goes. Good question. Okay. The next two, this slide and the next one are like little collages that I made. This is sort of representing what we're going to see in the hospital. So most of our hospital clinicals are going to focus on the labor and delivery side of maternal child health and then postpartum. Now, here's one of my, if I can get everyone out of this class to understand how very different these two are, it will be a successful semester. One of the hardest things to recognize in this specialty is that even though this is the same person, separated by a few minutes, the needs and nursing care for a laboring, delivering mom are drastically different than the needs and nursing care of a postpartum mom. And we're talking about minutes that separated, and it's the same person. But what we're going to focus on and what our care plans are going to look like are drastically different. Anybody know why? And you can use the pictures to help. What do you suppose some of our focuses are when we're taking care of a laboring mom? What'd you say, Sarah?
The mom.
Okay, yes, we are focusing on the mom. What'd you say?
Pain management.
Okay, why?
Too much pain might, put
I mean,
the mom in distress.
look what we named it, right? It's not supposed to feel good. It hurts. Who in here has been through labor before? 3 of us? Okay. That's a big focus. Keeping them comfortable, trying to go along with their plan of care, but also making sure who handles it. Baby. Okay. What else is our focus in labor and delivery? These are intrapartum patients. So we got pain, we're focusing on the mom.
Will the baby's health get wandering?
Yes.
Find the baby in the morning.
Yes, here. This is the single most important assessment we're going to do in labor and delivery. And let me just tell you, the baby runs the show. If the baby looks like crap, nothing else matters. I hate to say it. Nothing the mom wants really matters if the baby looks like crap. It totally changes the plan. Okay, so labor and delivery is staffed, or should be staffed, like an ICU. A laboring mom should be one-to-one with her nurse. Possibly the nurse might have like a triage patient. But it's because A laboring mom is really two patients, right? And the plan of care can change drastically. Okay, so baby runs the show. When we're watching fetal monitoring, you gotta monitor it constantly. Okay, what else? If you look at these pictures, what does it tell you about the role of labor and delivery nursing?
Lots of encouragement.
Yeah, which picture refers to that?
Oh,
Cheerleaders.
Yeah. But then the back.
It's real fun when you're trying to push with a mom and she suddenly says, I'm done, I'm not doing this, and she screams it. She doesn't help push, I mean, what's our plan, right? We need her to participate. Sometimes I like to say, you got yourself into this mess, you're gonna have to help us get out. But they don't usually like that as much, so I don't say too much. Okay. Why else might they need cheerleaders? Why else would a mom say, I'm done, I'm not pushing anymore?
They could not have like support, like single mothers.
Yeah, that's a really sad situation. One of the saddest things is being a part of a labor and delivery where the mom doesn't have a support person. That is so rare, but it's really sad. So those moms absolutely not only need encouragement like other moms, but you're the support person then too. What else? Why would she get a lot of support and cheering?
She might not be able, she might not think that she can do it by
Yes,
herself.
that's very common. I have to sometimes tell people vaginas were designed to stretch and let babies come out, but most people don't think that. And what do you think they think is going to happen?
They're gonna breathe.
Yeah, they think their whole lower body's going to break open and just explode. And I guess it's going to happen. But it's a fear. And think about it, all the endorphins, all the epinephrine, norepinephrine, all that stuff raging, so they're kind of, they have high anxiety time, sure. Okay, what else do we see up here? It tells us about the roles of labor and delivery nurses, what they focus on.
Looks like babies out to make sure that the mother sees them.
Yeah, bonding. So, this don't really have a great bonding picture here.
That, the one like the actual delivery section, because she's putting her head.
Thank you. Yes, they're about to do that, and that's where we like them to go. That's a big thing that's changed in the last 10 to 15 years. When I started in 2005, they were still very much like, oh, take the baby to the warmer and stabilize it, and you know. And now it's more like, don't do that unless they're having issues. This is a natural process. Most things go well if you just leave them alone, and so we try to put it straight to mom and keep it there if we can. If you haven't seen a C-section before, or you haven't seen one recently, there's a lot of really great efforts to make C-sections more personable and not so sterile looking like an OR. They have clear drapes now, and some of them are even, see how there's like a blue drape here above her? Some of them even have like a peak of blue. Yeah, some of them are they're clear or they have it lowered so the mom can see over. They'll do a lot more of showing, and then they're really trying to do skin to skin in the OR, which is just awesome. So that's exciting. But helping with bonding right away is a big role. What else?
I would say alleviating fear when it comes time where we just have to have a change plan.
Yeah. What example do you have? What kind of plans might change?
C-section.
Yeah.
Or if they've been pushing for a long time and they have to use different instruments.
Yeah, there's lots of things. For some moms, they end up having a vaginal delivery, but they didn't want to have an epidural, and they end up getting one. And they feel, for whatever reason, like failures. There's a really big problem in this country of like mom shaming. and making people feel less than because they did this kind of feeding or this kind of delivery or whatever. But yeah, whatever their envisioned plan is, however much they steer off of that can be very detrimental to some moms. For some moms, it's not the labor delivery part, it's postpartum, but they have their heart set on, for example, breastfeeding exclusively, and that has a rocky start or doesn't end up going well. That can be devastating for some moms. Just depends. Everyone's got a different plan. What else?
There's the ball on the person, like over on her knees, so different positions or techniques.
Are we talking about this one?
Yeah.
And then that one?
Yeah.
Yeah. What is this?
You sit on it and bounce.
What do you guys call this?
Yoga.
Okay. Does anybody call it a yoga ball or is it not?
Yeah.
Okay. Well, guess what? The same exact apparatus, when you put it on an OB floor, guess what it's called? Birthing ball.
Do they have peanuts?
They do. They have peanut balls, so I need to add that up. Peanut ball? Yes.
Peanut
The
and
pink
you
things over there.
mine was blue with the, they look like a peanut and you sit in between.
They're the same
It's
material.
so you don't fall as easily.
Oh,
Actually, that's not what it's for.
That's what they do.
But that's not what they told you. We don't trust you to stay in bed, so we're gonna give you a peanut ball. The peanut balls are made of the same material, but they're literally shaped like a peanut, like she said. But they use them for laboring moms who've already had an epidural or can't get out of bed. And they put it between their legs. And what do you think that helps with? They'll flip them side to side too, but they'll use that and position them. What do you suppose that helps with? Good. Oh, I love it when you guys have that. Oh, yes, that's a great one, but no. Was that you, Nate?
Yeah.
Okay. I don't know why, but I'm having a hard time over here hearing who says what. I keep thinking it's me. That's a great post-med-surg one answer. I will tell Sally. Good job. But these are young, healthy people. We're not really worried about skin breakdown as much. But what would the peanut ball do? What did you say?
I sat on mine.
Oh, you sat
Well, I
on it?
didn't have enough rope first, so they gave that to me.
You sat on the peanut ball?
Yeah,
Not this one?
no.
Yeah, that's what I've
Was
seen.
this in Utah?
Well, no. This is in Kansas City, actually.
Was it on the floor?
Yeah.
That's
They
why
put
so
like
much.
this.
I'm assuming they laid it the long way?
Yeah.
And you sat, so you were sitting way down, weren't you?
Yeah.
Was that hard to get up from? Was,
I was
okay.
kind of squatty because you know, like when you're like.
I'm not thinking some
squatting,
moms would
it's
be
like-
squatting way down, that would be hard to do.
Yeah, it was
I have
like
not
a
seen
bouncing
these out of
squat.
bed, okay.
Yeah. I don't know.
Was it busy that day? Were they out of these times? Because these are the ones you use when you sit on the floor. Interesting. But then you said you also used it, they.
I've used that one in another hospital.
Okay.
In Utah, I don't even think, no, I think I got that type in Utah.
But didn't you say they use the peanut ball also? So you
In
don't roll out of bed?
peanut, I've never used the peanut ball like that.
Oh.
I don't know,
I
that's-
thought you said they told you it was so you wouldn't fall in bed.
They see fall easily because they
Oh, I'm
because
sorry.
the peanut one is that's what they told me with my first delivery.
Oh.
So I was on the floor, so I was like, 'cause
I'm
this one's
getting it.
easier to
It
fall
is
off
easier to
of.
roll off this one.
Whereas the
Okay,
peanut
I'm
one,
getting it now,
you're
I'm
like
sorry.
straddling it, so it's not as easy to fall off of it.
Interesting.
I don't know.
Cool. Okay, well, when they came out first, peanut balls were used when women were in a bed, especially when they couldn't get up. What do you think it would help with? Feeling? Good thought, no. Let me ask you this. If you don't have an epidural and you're laboring, what do most moms want to do? Walk, move, change positions, right? That's one of the downfalls of getting an epidural, right? So the peanut balls, you can put the mom in different positions, but then if you put it between her legs, it helps her pelvis open, change shapes, baby's head rotates down, you switch sides, you can go back. So it's more stimulating of movement that she's not getting from being in bed. The key is frequent position changes, but the peanut ball helps with pelvic opening and fetal descent. Okay. other or her support person. That's another big role about the anxiety component. Besides the mom herself, you know who really has anxiety? Is typically the support person, if they're in a good relationship. But helping involve that person in helping the mom. I will never forget, kind of aggravating at the time, when I had my first child, I had him on the labor and delivery unit I worked on in the hospital, and my nurse was my preceptor, okay? And I was so proud of how well the delivery went because I didn't think it was gonna go that well, and my child was 9 pounds and 3 ounces. But I kept saying, didn't it go well? I was just so excited. And she kept saying, you did good, but Blaine did great. Blaine's my husband. Like 5 times she kept saying that. I kept thinking, okay, yes, he's wonderful, but he didn't do the hard work. But she said, as hard as it is to be the one in the bed, it's harder to be the support person. Because when they're really hurting or really feeling out of control, there's nothing they can really do for their loved one to take that away. And she said that's harder than being the patient. So I got it, I understand. But we want to make sure we don't forget that that support person is part of her care plan. So how can we involve that person in helping her? Okay, anything else you see?
Well, there's gloves, so I'm gonna say hygiene.
So like that's.
Okay, yeah, and what do you think we need hygiene for? Sterile gloves. Checking the cervix, yep. Very good, what else? Popsicles, why are these up here?
Is that for having?
Because they can-
Well, usually in labor, a lot of places will still do clear liquids only. Research says that's dumb. It's hard for us to change the way we've always done things. So a lot of times they're getting, ice chips, Jello, bomb pops. You give them what they want, right? And then after delivery, if it's a vaginal delivery, they can eat whatever they want. If they're unfortunately been laboring the whole time and then have a C-section, they're probably still gonna be in for a little bit and then ice chips and stuff like that. But you progress them as much as you can, as long as it's fitting for their situation. Okay, what else? Yeah, this is, guys will soon see that nurses manage labors. If providers had their wish, they would only come in to catch. So if it goes well, we would love them a lot. But labor is a process. So that's where the cervix checks help tell us how dilated, how effaced, and what the station is, or how far descended the baby is. And so we want to make sure if we're doing Pitocin or if they're in natural labor that we're seeing progress, and if not, it needs to be communicated. So yes, we're constantly assessing this with this. So what else? Urinating? Okay, where? Is there a picture you're seeing with that? Is that a little tube? Oh, this is a placenta.
That's what I thought
Oh,
at
it
first,
can't
but it
be.
looks like a little
It is
kitty.
not. But yes, they need to pee too.
But
This is a placenta and it's a happy one.
Okay, because I was like, the placenta, like, it looks a lot more messy than that
Oh,
little
yeah.
thing.
But you're right, it does look like a kidney.
Yeah.
I thought it was a stomach. I need a better placenta picture. How about that? Okay, so why are placentas important?
Because they have to get those out.
They do have to get those out. They're important for different reasons, depending on what point you are. If she's still pregnant and laboring, why is this important?
Still life support.
It is literally the life support, and we need it to work well. If this doesn't work well, we're going to see it on here. And nothing else matters. Okay. If everything goes well, baby comes out, then what did you just say?
They have to Yeah, push that lateral.
Even though it's considered one organ, it sometimes doesn't come out in one piece. So the provider needs to make sure the whole thing comes out. Why? What?
They can cause hemorrhage like that.
Absolutely. Even a teeny piece retained can cause hemorrhaging. Why? Her body gets confused as to whether it's still pregnant and the uterus needs to stay relaxed, or she's postpartum and the uterus needs to contract and control bleeding. So even a tiny piece of retained placenta creates this confusing state and can cause hemorrhaging quite quickly. Okay, the other thing is, when the placenta comes out, the provider will sometimes ask that it be sent to the lab for analysis, just like other tissue is. So in that case, we bag it, label it, and treat it like any other bodily specimen. So nurses are usually managing that. Yep.
Is there more common nowadays for people to ask for their
Yes.
placenta?
Yep, so much so that most places had to come up with a policy. Because it's living tissue,
Yeah.
and we tend to think, oh gross, I'm gonna take that home. But some people do, and so and their defense was, it's mine. You know, and it's kind of like, well, that's true, how do I tell her, you know? But they had to come up with safe ways to do that.
The mom that I nannied for, she asked for her placenta and she freeze-dried it and put it in smoothies.
Some people make stew out of it, I've heard of smoothies.
Pills.
There's companies now you can
Yeah.
send it to that will encapsulate it. Some people bury it, they believe in like the life-giving properties of it, they bury it in their backyard, there's symbols behind that. All kinds of traditions, cultural differences. Okay, what else? Anything else? I have a couple of C-section pictures on here, just sort of simulating that even if the labor and delivery part doesn't go as planned, we have to be prepared at any moment to be calm to circulating nerves for the C-section. Okay. And then as soon as the baby's out, we also become the baby's nurse. So we're assessing the baby as soon as it's out. When they put the baby up at mom, there's a lot of bonding that can occur while we assess it. We don't have to move it over to a warmer to assess it. Any idea how we could assess a baby while it's just born and laying on mom? Did you say APGAR? Okay, APGAR scores? I think I heard someone say color. Okay. Crying. What does color tell us?
Circulation.
Mm-hmm.
Jaundice.
What else does color tell us? Given the massive changes going on in this person, are their lungs going from fluid-filled to air-filled, right? Because in utero, we're breathing there, right? It's filled with fluid, amniotic fluid. So the color change also tells me how well are those lungs getting cleared out and passing oxygen back, especially after the cord's cut. If the cord's not cut yet, you can say, oh, there's oxygen blood coming from mom. But once the cord's cut, the color is definitely reliant on its lungs functioning, right? Okay? So I heard someone say crying, I think. What's crying tell us? Yeah, if they're crying, it tells me they've got energy to do that. And then the crying actually helps the lungs to clear the fluid out. Pressure pushes it out. Okay, what else?
You look for jaundice.
You probably won't look for jaundice yet. Most babies aren't going to be born, but that will be an important assessment as they progress in age. Did you say that wrong, or did something else? Okay, I want to make sure. It's so much better not having masks. It's easier to tell where people are coming from, but. Okay, anything else while it's on mom?
Muscle tone.
Yeah, what do you want to see with muscle tone? How would you know good versus bad?
Like if they're moving their arms and legs
Okay.
around.
Okay, is there effort to breastfeed or interact? Sure.
What about just overall, like, making sure they have all of their toes and fingers, like everything?
That's not a bad thing to do. A lot of that stuff though, if it's big, it will have already been caught on the
Yeah.
ultrasound. I mean, obviously, if something big sticks out, you'll see it, but you won't necessarily count those things. But you will be looking at it for any what we would call gross abnormalities, big things. Going back to tone, what else is normal about a baby's tone versus our tone? If I lay a newborn right here, what do I want it to look like laying on the table? What should it look like, shape-wise? Yes. If I take someone and lay them in their bed, an adult, what natural position, if they were just to lay in bed, do most people take? There's no way, right? I mean, obviously some people lay on their side, but their infants look like little Oompa Loompas. Like their arms are bent and their legs are bent. That's tone, and that's a good sign. You do not want a baby that's floppy. That is a bad sign. Okay. Okay, one more. Anything else we can do to check? Good thought. We probably won't do the actual reflexes yet. You'll see it root around. You may see it do that kind of thing. What else, when it's laying on mom, would give me a really good indication of how it's doing? It will require me to touch. That's it. That's an important one, but that's not what I'm thinking of. But it is very important.
It's not chest expansion because
No. That's not the one I'm thinking of. What were we watching so closely? Okay. And the coolest thing ever, you guys gotta feel this whenever you're in delivery. You can put your gloved hand at the base of the cord and just hold it and you will feel it pulsating. That's the heartbeat. I don't even have to put a stethoscope on. It's so cool. So I can let them bond. I can reach up and feel and say, oh, that's over 100. And look at what I just assessed without getting in the way of them, without going to the warmer and interrupting that bond. It's really cool. So try to do that with you guys in deliveries if they're like you. Okay, questions? Okay, so then in just a few minutes, we're switching our focus for mom to postpartum. Same woman, drastically different needs. Why?
She's a downstream recovery process.
What did you say, Landon? She's a recovery process.
Downstream.
Okay, why? How?
Supporting this life inside of her, trying to adapt.
I like to tell people that it took her body somewhere around 8 to 9 months to increase blood volume, change the size and weight and shape and cell number of multiple structures to accommodate a full-term fetus, right? 9 months, 8 or 9 months. And now it's out. So think about all the changes her body had to go through. It's now going to start doing them.
She's also getting milk production.
Yes, and the milk production was already taking root, but absolutely the focus has changed and there's probably going to be a baby feeding off of it. Or if she's not wanting to breastfeed, she still needs to expect that the milk will come in and we need to plan for that as well. But yeah, that's changed. What else?
It's going to be also pain management too.
Yes, different kind though. Sort of the same area, and it can hurt really bad afterwards too because of the cramping they can have. But we don't do epidurals postpartum. We focus on oral pain meds. And every mom's different. Okay, anything else? What do you think the focus is on postpartum?
Making sure that the bleeding isn't.
Did you say bleeding too? That is a huge focus. Why?
Too much is a sign of like hemorrhaging.
And they can hemorrhage literally to death very quickly. Does that happen a lot? No, not a lot, but that's why we don't let our partners, okay? I think it can be deceiving because they look young and healthy. But at any moment, technically, any uterus on a postpartum floor can say, I'm not gonna squeeze anymore and control bleeding, I'm just gonna relax. And she can hemorrhage out of that placenta site quite quickly. So we wanna focus on preventative healthcare. We wanna prevent that from happening, not wait till it's a crisis and intervene. That's the worst way to approach your job as a nurse. Okay, what else? What is the focus for postpartum nurses? Teaching, all the live long day. What are we gonna be teaching? How to breastfeed, okay?
Hygiene, like how to cleanse.
Okay. You mean for herself?
Yeah, like vaginal, she had like vaginal.
Sure. So we'll be getting them up to the bathroom and showing them how to use the water bottle, what stuff they can put down there, and how to clean and that sort of stuff. Are you guys able to hear okay, or do you want me to close that door?
I can hear.
You can, okay. What else are we gonna be teaching?
Signs of infection.
What'd you say, Chris?
Signs of infection.
Okay, signs of infection.
Like car seat stuff. how to
Yeah,
use
baby
them.
stuff, okay? So car seat stuff she mentioned, what else? Safe sleeping,
Swaddling.
swaddling.
And diaper changes.
Yes.
Like how many are normal.
Yep, or just the process of doing it. One time I took care of a family, it may have been the favorite call I ever answered, but the mom was sleeping, and the dad pushed the call up. And I went in the room and said, oh, she pooped. And I said, oh, that's nice. And then I realized, oh, he doesn't know how to change a diaper. You know, that's why he was calling me when to come do that. So that was teaching time. You know, it's kind of fun in this class because all of us have different amounts of experiences with babies, right? I mean, some of us have children, but many of us don't. But whether you have lots of cousins, whether you were one of the oldest or youngest, whether you have lots of siblings, whether you've never held a baby, I still have a picture from when I was in college and my husband met, I guess it was his cousin's child. He's one of the youngest in his family, and so he was like doing this. And he looked so uncomfortable, and I was like, what are you doing? But he never really held a baby. So, you know, that was foreign to me because I was one of the older cousins in my family, so we fought over the babies, you know. But yeah, don't forget that some of the simplest things are where teaching is gonna occur. Somebody said safe sleep, somebody said car seat. Those are the things literally that save lives. Breastfeeding alone, they've done research that if 90% of women, or 90% of babies were breastfed for the first year of life, we would save 1,000 lives per year, and something like $18 billion in health costs. So I always tell people all the times I've hung over a bed and helped a mom who can't sit up because she had a C-section breastfeed, or spend that time, that's how I'm saving lives, but it's not immediate, it's down the road. All right, what else are we gonna teach? Diet, exercise.
Postpartum blues, psychosis.
A lot of the things that could happen for mom or baby are not probably gonna happen in the hospital. So we have to do really good education to not only her, but her support people of what to watch for baby and for her after they go home. It's really easy in the hospital when you can just ask someone. It's a lot scarier at home. Every baby's different. I always used to joke that I wish the placenta had a baby manual for that baby, and it like came out with the baby and told you for this baby, when they make this sound of this, or when this happens, do this. But they don't. So there's a lot of work that goes into learning that baby. Okay, any other thoughts on postpartum?
Making sure that the baby's adapted well to the
Yeah.
external life.
So we're going to continue to assess both mom and baby routinely throughout their stay, just to continue monitoring. The goal is that they're both well. They're not, in general, a mom who has a baby and her newborn are not ill people. And that's one big difference about these hospitalizations, is these are not typically illness-based hospitalizations. It's always fun having students in clinical whenever they're doing paperwork on a newborn. And just like most of your packets, it'll say reason for admission. And students really struggle at first with, why was this baby admitted? And why do you think they were admitted to the hospital? What would we put? Birth. Term birth. Birth by C-section. Something like that. That's why it's admitted to the hospital. So how simple, right? But that's a very wellness-based diagnosis, not illness-based. Okay, why don't you guys take a 5-minute break? Sometimes I forget, so let me know if I've gone on a break. Trinity nursing. So I wanted this to come from you guys to start with. What do you think is going on as far as issues and trends in the United States for maternity nursing now as compared to 10 years ago, 20, 30, or even 40 or 50 years ago? What's changing? What are we? What's the cool thing going on? What's different? What's changed in various countries? Okay, more female doctors. Okay, good one.
There's a lot more concentration on reducing disparity.
Yes. And what do you mean by that?
Trying to bridge the gap between infant and mother mortality versus minority or Caucasian.
Yes, that's gotten actually a lot of attention in the last few years, finally. Is there significant disparities across different racial groups for maternal mortality rates and infant mortality rates? Especially the one getting a lot of focus is maternal mortality rates. And the fact that our overall maternal mortality rate is embarrassing in this country. Okay, what else?
Increase and decrease of disparities.
What do you mean by that, the increase and decrease? That's always a big topic, for sure.
Well, so there was a significant increase, like in the 90s, early 2000s,
Yeah.
That.
Why was there a big increase?
Of what, birth parity?
Disparities. Why was there an increase?
101, 102.
It's a major surgery to have done. Why do you think the C-section rates increased? And how is it more convenient? Sure it can. And you can deliver it in a much more narrow window than waiting for her body to labor. Because we don't know if she's going to deliver in 12 hours or 15 hours. Okay, so there was a convenience factor, which is not why we should be making decisions, right? But that affected it. What else do you think affected the the C-section rate?
It was less painful for the mother.
Well,
I feel like that's debatable, but sure.
I feel like a lot of people that aren't educated feel like that, because I never knew how bad they were to my sister and and I just thought it was like,
Why do you think people think they're better? Like what you're saying about people who aren't educated about it. Why do you think people think they want a C-section?
maybe because it's, like you said, faster, and it seems like you're not pushing the entire baby.
And it's
out.
not called labor, right?
Yeah.
Doesn't sound as bad. What do you think people think a C-section's like until they witness one or experience one?
No big deal.
I like to say that I think, just from my years of doing this, that people think you lay the mom down, you unzip her belly, you lift the baby out, and you zip it back shut. I think that's what they think. It is not that way. Why do you think people think it's that simple?
Misinformation.
What?
Misinformation.
Misinformation? Okay.
I feel like it's not talked about. Like a lot of people, I feel like think that a C-section isn't actually giving birth. It's like an easier way out. Kind of.
I think that we think that because it's so common. It is a commonly done surgery, and so I think when something's common, we think it's not a big deal. But until you watch a C-section, first of all, I should preface this by saying C-sections are a wonderful alternative. We are so lucky there is another way to deliver babies because some women need them. They save lives. They're also more likely to cause problems with death. So they should be reserved when they're needed. And they're often not used in that way, and that's what's wrong. But we're very lucky to have it as a life-saving measure like we did. Okay, so good input here.
I have
So
a
you
quick
guys say
question.
people are uneducated, yes?
Alright, could there have been a correlation that the rise in C-section was also comparatively, what am I trying to say? Decline in better maternal care?
Do they think the increasing C-section rate is related to the declining care?
And then when maternal care became better, C-section rates also came down.
Yes, I think some of those things are tied together. We'll expand on that. Why else do you think, even if they were done because they needed to be done, what do you think caused that?
It's a weird, who knows?
Lack of patience for the learning process.
Okay, we did definitely lose patients in the learning process. That's true. Many would debate the consistent use of fetal monitoring. So watching a baby at all times has drastically increased our C-section rate. Why? Yes, because we can see every little thing that goes wrong. And in the United States, we have a very interventionist healthcare system. We have a really hard time saying, let's just watch and wait. We are a litigious society, and so if we're not doing something, we think we're being negligent. But what we're finding is that when we do too much, we cause more problems. We're really bad at taking our hands off and letting things run its course. So as soon as we started doing consistent fetal monitoring, absolutely C-sections went up. Okay, what else happened in the 90s that probably also contributed to C-section rates? So we're doing more fetal monitoring.
Ultrasounds.
Ultrasounds, very good, and what else? Have you guys ever heard your mothers and grandmothers talk about what it was like when they had a baby? How is it different than how people have babies now? Yes, what do they say?
They would say when it was
In my day,
Yeah.
you girls are pansies now. In my day, we didn't have epidurals. What else is different from when moms, grandmas, great-grandmas had babies?
A lot of my aunts were literally born in barns.
Oh, so location was different.
Well, care, it went from more midwifery care in home to
Okay, more hospitalized.
more hospital, more
Okay. Epidurals took major flight in the 90s. Now, epidurals are relatively very safe. However, as we will learn later, one of the big side effects that we know from epidurals is they drop blood pressure. We know that. We try to bolus them beforehand to prevent that. However, if we're watching this while giving an epidural, think about how many babies started having late B cells or crappy variability and went to have a C-section. That if we hadn't had an epidural and we hadn't watched this, we probably wouldn't have. Oh, very good. Increase in inductions, that's probably the number one reason. Now, why did inductions go up? First of all, what's an induction? Just to make sure we're all on the same page.
when you forcefully go to labor, like medically.
Yes.
It is when you force the mom's body to labor. Force is like not the best word, but I can't think of one to get the point across. You're inducing the process of labor instead of letting it happen naturally. Why are those more common now? Yes, they help us plan our lives because we're control freaks by a society standard. You've got to have control over everything.
Ultrasound.
Okay, well, yes, ultrasound.